The Impassion030 or ALEXANDRA study was a global phase 3 collaborative effort enrolling patients with stage 2 or 3 triple negative breast cancer who went for upfront surgery to receive adjuvant chemotherapy with or without checkpoint inhibition in the form of atezolizumab, together concurrently with chemotherapy, and then as monotherapy to complete 1 year in the adjuvant setting, with a primary endpoint of invasive disease-free survival. So the study design was a 1-to-1 randomization. The plan was to enroll 2,300 patients with stage 2 or 3 triple negative breast cancer who went for upfront surgery and randomized them to receive adjuvant chemotherapy with or without atezolizumab in this open label global phase 3 study. The primary endpoint was invasive disease-free survival. After an independent data monitoring committee reviewed the study data after 2,199 of the 2,300 planned patients were enrolled, a recommendation was to pause enrollment. The FDA requested an interim analysis, and based on that interim analysis, enrollment to the study was discontinued at that time. So at 2,199 of the 2,300 planned patients. So the bottom line is that the addition to atezolizumab to adjuvant chemotherapy in this high-risk triple-negative breast cancer population did not confer any benefits. So there was no improvement in invasive disease-free survival with the addition of checkpoint inhibition, and that observation was consistent across all the subgroups interrogated. So it was a negative randomized phase 3 study. These results are incredibly important in that they underscore the current clinical practice, which is preoperative or neoadjuvant chemotherapy administration together with checkpoint inhibition in accordance with the Keynote 522 data, which led to multiple health authority approvals for this combination in high-risk triple-negative breast cancer. So there does not appear to be a role for chemotherapy with checkpoint inhibition in the adjuvant setting. Co-administration in the preoperative setting is critically important and may be a function of a couple factors, both an in situ tumor to which a robust immune response can be developed, and then intact lymphatic chains, which are still present prior to surgery, which may help with T cell maturation and cell cycle immunity. So we have a robust correlative plan. The study is supported by the big cooperative group, as well as Frontier Science and the Alliance Cooperative Group together with Roche. And there is amongst the academic partners a robust translational plan to see if we can further develop insight as to who is likely to benefit from therapy, if there is indeed a subgroup, and even who is at risk of developing checkpoint-mediated immune toxicity. The other study that we presented at EBCC was the Keynote 756 study. This is a study that enrolled just under 1,300 patients, randomizing them 1-to-1 to receive preoperative chemotherapy with or without pembrolizumab. The population that was eligible had stage 2 or 3 estrogen receptor positive, grade 3 early stage breast cancer. Patients who were randomized to receive pembrolizumab continued to receive pembrolizumab after surgery, so in the adjuvant setting together with standard of care endocrine therapy. And what we showed at multiple meetings now is that the addition of pembrolizumab to neoadjuvant chemotherapy in this high-risk hormone receptor positive population improved pathologic complete response rates by 8.5%, and that benefit was observed regardless of the definition used to define pathologic complete response. The event-free survival data is not yet mature. So importantly, the Keynote 756 study has two co-primary endpoints, both pathologic complete response and event-free survival. So that event-free survival data is highly anticipated, and it is anticipated that health authorities will want to see that event-free survival data before considering an indication in this high-risk population.